said, my name is Jennifer Gillick, and I am the program director here at the Northwest chapter of American Parkinson's. I'm so glad that you can join us for the next installment of this Take Control series. We do this series about every other month, and we bring in experts and just talk about things that are relevant to living with Parkinson's. I am very excited to welcome back Dr. Pravin Khemani to this series. He has spoken on a couple of topics here, and they've all been very well received. So before I introduce him, I'm going to share with you some expectations about the program. It's going to be probably a little over an hour long, maybe an hour 15. It's Zoom, so if you need to go, you can go ahead and log off. But we wanted to include time for your questions. Some of you have submitted questions in advance. You can pose a question at any time. If you just look down at the menu in your Zoom, you'll find the Q&A function. Just click on that and type your question in there. And we will try to answer as many as we can. Please keep your questions general and relevant to this topic, and we will try to get to them. We are recording this program, and it will be available on the APDA Northwest YouTube channel next week. And I will be sharing a link to that, as well as Dr. Khemani's slides, with you in a post-event email, which you'll get next week. So you can take mad notes, but I will share the slides, and you can always go back to the recording. So as many of you know, APDA is the largest grassroots network dedicated to providing programs and services to the Parkinson's community. We increase the public awareness and knowledge about PD as a major health crisis, and we invest in research designed to find effective treatments and ultimately a cure. We really believe that education is empowerment. So the more you know, the more that you're able to be empowered in living with Parkinson's or take control. Our sponsor, I want to thank for this program, is Aegis Living. They are a senior living company, and they have communities throughout Washington, California, and Arizona. And their financial support of APDA really allows us to offer free programs like this one. And so I really thank Aegis for valuing education programs like this. So now to the main event, which is all about levodopa. Levodopa has been the mainstay of treatment in Parkinson's since the 1960s. And there is a lot of information, misinformation, myths and facts about levodopa, which we are going to try to clear up today. So I am very pleased to welcome Dr. Pravin Khemani to this program. Dr. Khemani is a neurologist who is fellowship trained in both neuromuscular disorders and movement disorders. He practices at Swedish Medical Center in Seattle, Washington, and he is the author of a number of publications on Parkinson's disease. And frankly, we love Dr. Khemani, and he is an all-around great guy. So please welcome him to the screen, and thank you very much, Dr. Khemani, for being here. Hello.
Hi, Jen. Hello, everyone. So glad to be here today. Thank you, American Parkinson Disease Association, Aegis Living, my colleagues at APDA, Jen, Kirsten, Jean, and everyone. It's so good to see you guys, although it's online, and a whole bunch of people who have signed up. So we'll try to make it fun and interactive at the end during the Q&A session. With that, I'll share my screen. Jen, if you don't see it, you don't hear me, just interrupt me at any time, or I'll just keep going.
Okay, will do. So I'm going to disappear. You share your screen, and I'll see you for the Q&A.
Got it.
I see your slides. You're in good business.
Oh, that's fantastic. Thank you very much. All right, so we're going to talk about levodopa, but I thought I might pepper my presentation with some random slides of places I have visited just to break the monotony. And this is one of my favorite places to visit. It is a beautiful sculpture garden in Minneapolis called the Minneapolis Sculpture Garden. And a lot of you probably recognize this very popular sculpture called Spoon, Bridge, and Cherry, and it's quite massive. There is a fountain around it, and it's a really fun place to be. So with that, let's jump right into the topic. We're going to talk about some facts and some fictions associated with levodopa, and try to demystify what levodopa is intended for, what it is supposed to do, do a little bit of a historical timeline, talk about the metabolism of the drug, present a case study from my clinic, and talk about some truths and some mythology surrounding the medication, and also discuss a little bit about how we use it in clinical practice. In clinical practice, levodopa always means carbidopa and levodopa. Both of these drugs come packaged in a pill. Carbidopa is the inert portion of the drug which prevents the metabolism of levodopa to dopamine, and we will see why that is important. The medication is most commonly marketed as Sinemet. All right, so let's go really way back into time, 300 BC, where from where texts are discovered talking about a disease resembling Parkinson's disease, for which beans of the tree Mucuna pruriens were used to mitigate tremors and perhaps increase speed and movement and mobility. The descriptions are not as thorough and as good as Dr. James Parkinson's description of a collection of patients in his clinic who had the cardinal symptoms of Parkinson: the tremor, the slowness, the stiffness, the difficulty walking. And in his honor, the name Parkinson's disease was given to the set of symptoms, and we recognize Parkinson's disease as a distinct disease. Between 300 and 1911, a lot happened in science, and a lot of brain research was done, particularly research in brain neurotransmitters. And in 1911, levodopa was synthesized in the lab. As I said, very early on, it was obtained from natural resources from the Mucuna plant. Between 1911, 1940s, and 1960s, levodopa was given to people with post-encephalitic Parkinsonism. We don't see much of this. This disorder has sort of gone out of fashion. At that point, we suspect that a lot of these individuals who improved with levodopa had Parkinson's disease, but the neurotransmitter or the pathological basis of Parkinson's disease was not identified. And there was an incidence of virally associated Parkinsonism, which improved with levodopa. 1960s and 70s were very important in identifying the link between dopamine and Parkinson's disease. It was noticed that there was a decrease in dopamine in brains of people with Parkinson's disease examined post-mortem. And this was a very important discovery, which consolidated the belief that levodopa, which gets converted to dopamine, is indeed the medication to improve motor symptoms in Parkinson's disease. In the mid-70s, levodopa was officially marketed as carbidopa-levodopa to treat Parkinson's disease. There were many people that were involved in this endeavor of discovery of dopamine and improvement of motor symptoms of Parkinson's disease. But the most noticeable name is Arvid Carlsson, who received the Nobel Prize in Physiology or Medicine in 2000 for the discovery of dopamine. And levodopa continues to be the mainstay of treatment for Parkinson's disease. We have many different forms of delivery or intake of levodopa that continue to be reinvented to improve its efficacy and tolerance. We are well versed with the symptoms of Parkinson's disease, but I thought I might just set the stage for the utility of levodopa in Parkinson's disease through this slide. We know that Parkinson's disease is a collection of motor symptoms, including slowness, stiffness, rest, tremor, problems with gait and balance, soft speech, difficulty with handwriting and manual dexterity, swallowing, dystonia, and cramps. Not everyone has every symptom, and not every symptom is equally severe in everyone. So there is a lot of, as we say, clinical heterogeneity in the symptoms of Parkinson's disease. But Parkinson's disease is not just a motor disease, especially over the past 30 to 40 years. We have recognized that it's a constitutional, multisystemic disorder, which manifests as motor and non-motor symptoms. And there are myriad non-motor symptoms, include those affecting sleep, causing behavioral and cognitive changes, pain, fatigue, skin changes, visual changes, restless leg syndrome, and a collection of cardiovascular, gastrointestinal, genitourinary, and sexual symptoms that are collectively called autonomic symptoms. And so Parkinson's disease, like a few other diseases out there, causes autonomic dysfunction, which presents as orthostatic hypotension, which is a fancy word for lightheadedness when standing due to a precipitous drop of systolic blood pressure. Parkinson's disease is also responsible for blood pressure fluctuations. Not only do you have lows, but you can have dangerous highs, and this is called supine hypertension. Additionally, constipation, urinary frequency, urgency, erectile difficulty in men, reduced libido, and a whole host of other sexual issues can be present in both men and women with Parkinson's disease due to autonomic dysfunction. Having said that, I'd like to come back to levodopa, which is designed specifically to treat the motor symptoms of Parkinson's disease. And that's what we will be talking about today. In my practice, levodopa has shown to improve a lot of non-motor symptoms indirectly, but it is not marketed or designed to treat non-motor symptoms as it is motor symptoms. So how do you diagnose Parkinson's disease? Because obviously, in order to give levodopa to someone, you need to have a diagnosis of Parkinson's disease. And we have clinical diagnostic criteria, which we use. These are called the Movement Disorder Society diagnostic criteria that were put forth in, I think, 2015 or 2017. And they have levels of probability of diagnoses of Parkinson's disease, with clinically established Parkinson's disease being the highest level of probability, and clinically possible Parkinson's disease being one level lower than that. Now, it is important to recognize that autonomic dysfunction and cognitive changes can occur in Parkinson's disease, but they occur much later, typically, than other diseases that look like Parkinson's disease. And those are called the competing diagnoses or mimics of Parkinson's disease. The two that we most commonly see that can present as Parkinson's disease much earlier on, that is the first 1 to 3 years when symptoms start, are diffuse Lewy body dementia and multiple system atrophy. Parkinson's disease, diffuse Lewy body dementia, and multiple system atrophy are together linked and lumped into a classification which is sometimes termed alpha-synucleinopathies. Alpha-synuclein is the abnormal protein that accumulates in the brains of Parkinson's disease, diffuse Lewy body dementia, and multiple system atrophy. However, in diffuse Lewy body dementia, there is a much earlier presentation of cognitive impairment compared to Parkinson's disease, and it can present as dementia, psychosis, confusion, delirium, delusion, visual changes, and not very dramatic either. There can be hints of all of these symptoms. And diffuse Lewy body dementia can cause fairly severe autonomic dysfunction much earlier in the course of the illness Compare to Parkinson's disease, and that presents as low blood pressure, urinary frequency, and urgency. So timelines become really important, and the severity of symptoms becomes really important. And it is also important to exclude other things that could cause urinary problems, blood pressure. So all of these diseases have inclusion criteria, that is positive symptoms, but a whole host of exclusion criteria that we use to eliminate or basically ensure that we are making the right diagnosis and there are not other conditions that are causing these symptoms. Multiple system atrophy presents much earlier than diffuse Lewy body dementia, and the hallmark of MSA is early and fairly severe autonomic dysfunction. It is not very well documented how levodopa works in diffuse Lewy body dementia and multiple system atrophy, but as a general rule, and based on my clinical practice, it doesn't really work well in DLBD and MSA as well as it does in Parkinson's disease. It actually can exacerbate a lot of the cognitive and behavioral issues and worsen autonomic dysfunction. So severe intolerance to levodopa very early on in the disease should raise concern for a condition other than Parkinson's disease. Let's talk a little bit about how levodopa gets into the brain, because that's where it actually gets converted or should get converted to dopamine, which is the essential neurotransmitter for normal movement. But it has a fairly long journey from the mouth through the stomach into the small intestine where levodopa is absorbed, and then from there into the bloodstream through the liver and pumped through the heart up into the arteries and into the brain. So if there's any blockage, so to speak, between the mouth and those arteries, levodopa may not get in as effectively into the brain as it should. There are other organs that are involved in the metabolism of levodopa, but we're not going to do a deep dive into that today. Liver and other organs, including the bile, gallbladder and pancreas, etc. Everything typically goes through the liver to be metabolized first before it gets to other organ systems. And the blood-brain barrier is a collection of cells, of various kinds of cells that line arteries in the brain, and that is to protect things from getting into the brain. But fortunately, levodopa can hitch a ride on a protein and get into the brain and try to get to where it needs to go. Obviously, we would like levodopa and all other brain-specific medications to get to exactly the place deep in the brain called the basal ganglia in order to be converted to dopamine, but that doesn't happen. There is no channel or pathway, so levodopa can actually go to various parts of the brain, even those parts that you don't want it to get to, which can cause side effects due to the medication. It is important to recognize that a slow gut can delay absorption of levodopa, and unfortunately, a slow gut is an autonomic complication of Parkinson's disease. This would be the first time I'd put in a plug for our Education Empower Engage series, which is going to be held over a 2-day period, February 15th and 16th. If you haven't registered, please do so, because we will be talking about GI symptoms in Parkinson's disease in more detail. Before levodopa gets to the brain, let's see what happens to it in the body. It gets broken down into dopamine and another molecule called 3-MD. Well, this is not a good thing. And the reason is dopamine does not cross through the blood-brain barrier. It cannot get into the brain. So we do not want levodopa to be broken down into dopamine before it actually crosses into the brain. Levodopa can beautifully get right into the brain by hitching a ride on this special protein. So what we should do is to prevent the conversion of levodopa to dopamine, to maximize levodopa's entry into the brain. But additionally, dopamine is extremely nausea-provoking. And for those of those of you who've taken levodopa or Sinemet, you may have had nausea, and this is the reason why, due to the premature breakdown of levodopa to dopamine. That's why levodopa is packaged with carbidopa, which prevents the breakdown of levodopa to dopamine in the body. Occasionally, we use another class of medications called catechol O-methyltransferase inhibitors, COMT inhibitors, to further prevent the breakdown of levodopa to 3-OMD. So as much levodopa as possible can cross into the brain. In the brain, levodopa is converted to dopamine. We also use other medications called monoamine oxidase B inhibitors to prevent the breakdown of dopamine into other molecules such as dopag, because the active neurotransmitter dopamine is what is responsible for movement, and we'd like to maximize the brain availability of dopamine. So as I mentioned a little while earlier, levodopa converted to dopamine can cause nausea. How do you prevent that? Well, we can add extra carbidopa, which you take with every dose. However, for some unknown reason, carbidopa is very expensive. So that may not be a very good strategy. Additionally, if you remember, I talked about slow gut. And there are three terms that we will talk about in more detail on February 16. Gastroparesis, which is delayed emptying of the stomach into the intestine. Constipation due to a lack of movement of the intestine. And dysbiosis, which is a problem with the microbiome, the bacteria in the gut, which can reduce the efficacy of levodopa absorption into the bloodstream and its passage into the brain. We use anti-nausea agents if there is a significant intolerance of levodopa due to nausea, and we always start low and go slow. So we have ways of making levodopa much more effective or much more bioavailable through these tips and tricks. All right, for those of you from Minnesota, you might recognize this majestic sculpture, which is also in the Minneapolis Sculpture Garden. And I thought it's much more beautiful in person, and it is in the center of the sculpture garden, so you can see it from all around it. There is a story associated with it, which you can read in the museum brochures. It's a fun story. All right, so let's talk about a real-life case study from my clinic about Mr. H.W., who is a 61-year-old man with a 6-year history of progressive stiffness and slowness of his left hand, mild difficulty with gait and balance, and slightly soft speech, including occasional constipation and acting out his dreams. Now, his examination showed Parkinsonism, which is a term we use to describe slowness, and using the clinical diagnostic criteria, his neurological exam was most consistent with the diagnosis of Parkinson's disease. Because of these motor issues, he was not able to work effectively as a mechanic. The stiffness in his hand was quite bothersome. However, he was afraid of taking levodopa, although it had been 6 years since the start of his symptoms, because he had heard that it might accelerate the progression of the disease or that it could be toxic. He was also concerned about premature dyskinesias, and he wanted to, quote unquote, save the medication for the future. And he said he got his information from the internet and some support groups that he attended. So before we go on to talk about how we treated Mr. H.W., let's look at other aspects of levodopa, including some facts and fictions associated with it. Let's tackle the first one. Levodopa is toxic. It accelerates PD. Parkinson's disease. I wish we could have a poll, but since we don't, I'm just going to give you the answers. And that, what I just said, is absolute fiction. Levodopa is not toxic. It does not accelerate Parkinson's disease. And we have scientific evidence in the pre-levodopa area. Melvin Yar, Dr. Wolf, and other colleagues looked at brains of people who had with Parkinson's disease who had not received levodopa, compared it to brains of people who had received levodopa, and this was post-mortem, obviously. At that time, carbidopa levodopa had not been fully accepted or even, I believe, FDA approved for the treatment of Parkinson's disease. So they were able to do these studies, and they documented that the neuropathologically, there was no change in people who were exposed to levodopa versus who were not exposed to levodopa. And that's a powerful study, which we cannot do in these times because levodopa is so acceptable as a treatment for Parkinson's disease due to so many other scientific studies done afterwards that it would be unethical to take a group of people with Parkinson's disease and not give them levodopa throughout the duration of their life. And that speaks to the importance of levodopa in the treatment of Parkinson's disease. How about delaying levodopa is a good strategy? That is also fiction. Several studies now have shown that delaying levodopa is not good. Earlier treatment reduces long-term disability, in fact, reduces mortality compared to the untreated states, and overall improves quality of life. And one of the biggest studies, again, that we cannot do today came from Dr. Rajput in Saskatchewan, who is an eminent researcher and clinician of Parkinson's disease back in the 70s. Canada did not adopt carbidopa, levodopa for a long time. I think it was part of the NHS system starting in the late 70s or the early 80s. So Dr. Rajput and his colleagues followed patients who were not on levodopa therapy for a very long time versus those patients with Parkinson's disease who were getting levodopa. And this is a very long-term study of, I think, 10 to 15 years. And they realized that the overall longevity and longevity in the group that received adequate levodopa to treat Parkinson's disease was much higher than in the group that had either not taken levodopa for the entire duration of their life or had started it late. That's an extremely powerful long-term epidemiological study that we will not be able to do today, but that's a very powerful evidence that, number one, levodopa is not toxic, and earlier treatment that actually improve longevity. One of the things that actually worsens the quality of life, which I see amongst not just patients, but healthcare providers, is levodopa phobia. And I cannot tell you how many times people have come into my clinic afraid of taking levodopa because probably their healthcare provider didn't prescribe it to them, but severe dystonia causing contractures, musculoskeletal problems due to prolonged stiffness and slowness that could have been avoided had levodopa been initiated early on in the course of their illness. How about saving levodopa for later or for better results and less usage in the future? Well, that is also complete bunkus. The dose of levodopa needed for treatment depends on the duration of the disease and individual needs, and not when the medication is started. And I have prepared this cartoon here that I call the brain dopamine tank. Think of this tank over here as a reservoir of dopamine in the brain. And in Parkinson's disease, unfortunately, that reservoir is leaky, is losing dopamine due to a progressive loss of dopamine, the dopaminergic neurons. In the first year of symptoms, you probably need a certain amount of levodopa to make up this deficit, which is demonstrated by this bidirectional red arrow. In year 5, you probably need a lot more levodopa because the deficit is that much more. And in year 10, because of a much larger deficit, you need a commensurate amount of drug in order for it to be effective. And this holds true whether you treat or whether you replenish dopamine in that first year or year 5. You would need the same amount of levodopa in year 10 to make up the deficit. It really doesn't matter whether you've taken it or not in year 1 or 5. So I'm hoping this cartoon sort of illustrates the fact that the dose is dependent upon the duration of the disease and the loss of dopamine cells in the brain. How about the fact that levodopa becomes ineffective down the road? This is also absolute fiction. and Dr. Alskog and his colleagues at Mayo Clinic have shown this, and through pharmacological and pharmacokinetic studies, that levodopa retains efficacy throughout. However, the duration of response may shorten from maybe 6 hours to 2 hours and 3 hours. And the duration of each individual dose reflects the extent of dopamine cell loss. So it is basically the state or the status of the brain that governs the amount of levodopa you take and the duration of response. It is also important to recognize that the diagnosis of Parkinson's disease is secure and accurate. And I would refer you to an article in the winter edition of APDA Pathfinder on how we diagnose Parkinson's disease. And you can connect with Jen after this particular presentation to get some of these links, because this talk is sort of very interconnected with other talks and articles that we have presented before. The diagnosis of Parkinson's disease is important is very important to confirm, because initially many diseases, as I told you, Lewy body dementia, multiple system atrophy, and there are a couple others, corticobasal degeneration, progressive supranuclear palsy, they can mimic each other significantly earlier on. And they may be somewhat responsive to levodopa in the early stages, but as a disease progresses, levodopa loses its efficacy in these other diseases. So it's important to come back to the drawing board if the physician thinks that levodopa is not as effective as it used to be in the initial stages. How about levodopa accelerates dyskinesias? This is, again, a very, very popular myth, so this is complete fiction. Dyskinesia in Parkinson's disease depends on the duration of disease and the age of onset of the disease. And it is well documented that young onset Parkinson's disease is much more prone to dyskinesias, and that is because of a much larger deficit of dopamine in the brain, a higher degree of dopaminergic denervation, and hence the earlier age of onset. It is the individual dose of levodopa, not when it is started, that governs dyskinesia. So when we decrease the individual dose, the dyskinesia is mitigated and eliminated. Now, obviously, when you decrease the dose of levodopa, you may decrease its efficacy as well. So in advanced stages, we try to decrease the dose of levodopa, but give it more frequently. Dyskinesia, unfortunately, is inevitable in a majority of people with Parkinson's disease within 10 years, and in young onset Parkinson's disease in the first 3 to 4 years. However, not all dyskinesia is bothersome. In fact, a majority of the patients who come into my clinic have some amount of dyskinesia that they're not aware of, but they're moving really well. Their mobility is excellent. Dyskinesia may bother the caregiver and onlookers more than the patients, which is usually the case. And Michael J. Fox is a good example of someone who prefers to be dyskinetic rather than off. And we will talk about on and off in a little bit, but I would still refer you to some of the links on APDA if you're not clear on what is dyskinesia, what is the off state, what is the on state. Not all dyskinesia is bothersome, but when dyskinesia begins to interfere with activities of daily living, gait and balance, etc., then it must be treated. So fear of dyskinesia or acceleration of dyskinesia is not a good reason to not take the medication. This is one of my favorite sculptures. It's called Woodrow by artist Deborah Butterfield, and it looks very different depending upon your perspective. So if you ever go to the sculpture garden, look at it from all sides. And it is made out of metal. It looks like sticks. I think it is a remarkable sculpture. All right, so that could have been my transition slide. Now we talk about something which is actually a fact, that levodopa may not work well in some individuals, and that is absolutely true. every medicine has its efficacy depending upon the person's constitution, their brain wiring, etc. About 8 to 10% of people do not respond as adequately to levodopa as we'd like them to. And I'd like to introduce the concept of pseudo-resistance to levodopa. And we'll tackle each of these items individually. Is the dose adequate? Are they intolerant to levodopa that they cannot increase the dose? Is their gut moving slowly, and they're not absorbing levodopa from the gut, so a majority of it is not effective? And then there are things that are levodopa blockers. We will also talk about which motor symptoms respond preferentially to levodopa and which don't. What happens in older individuals? And again, I come back to the diagnosis of Parkinson's disease being secure, because if it isn't, levodopa is not going to work well. What is levodopa pseudoresistance? Levodopa pseudoresistance is a phenomenon that we see in clinic in people with Parkinson's disease, which sometimes baffles us as the Parkinson's disease diagnosis is very secure, but why is levodopa not working? Because it is supposed to work in 90 to 95% of people throughout their lifetime really well. Well, one of the issues could be inadequate dosing. You typically need about 600 to 1200 milligrams of levodopa per day, depending upon the stage of the disease, in order for it to be effective, and before you declare levodopa failure. In fact, that could be a red flag that the patient does not have Parkinson's disease and something else is going on. I typically give patients about 1200 milligrams per day. Now, if you're not able to tolerate levodopa, it does not mean that levodopa is not working or ineffective. And if you're not able to tolerate levodopa, then you cannot increase the dose to 600 milligrams. So the first thing one's got to do, or the physician's got to do, is work with the patient to increase the tolerance of levodopa. And the most common side effects of levodopa are nausea and bloating and dyspepsia. Unfortunately, Parkinson's disease predisposes us to these symptoms to begin with due to the slow gut phenomenon. Levodopa can exacerbate it. Now, we talked about metabolism of levodopa. If levodopa is prematurely being converted to dopamine in the body, then it can cause excessive nausea. In some people, there are very high levels of the enzyme in the body that convert levodopa to dopamine. And that could be the reason that it's not tolerated due to nausea. It can also cause dizziness upon standing and psychosis, confusion, and delirium, but usually not early on in the disease. This may happen later on with excessive amounts of the medication. So if this happens earlier on, then we have to determine why that is going on. Is the diagnosis secure? And if it is, what can we do to improve tolerance of levodopa? Intolerance of levodopa, as I mentioned earlier, is most commonly due to three things in our clinic: gastrointestinal system problems, orthostatic hypotension, and psychiatric and cognitive problems, which happen in advanced Parkinson's disease. We have an article coming out in the summer edition of Pathfinder, and this table is a sneak peek to that article. We are talking about levodopa intolerance in that article, so kindly get it, read it in detail. But just as a few tips over here, if you're having gastrointestinal problems due to levodopa intake, dietary modification is helpful. Eliminating red meats and excessive amounts of protein and dairy may be beneficial. Ginger products could decrease the nausea associated with it. And if you really cannot take levodopa on an empty stomach, take it with food that does not have a lot of protein. From the physician's perspective, we always start low, go slow. We involve the primary care, the nutritionist, and the gastroenterologist if there is a significant amount of GI problems, because you also want to make sure that the patient does not have H. pylori infection. They don't have an obstruction, in their intestines somewhere. They don't have a primary GI problem that is causing problems with absorption of levodopa. Having done all of that, if the problem still persists, then we treat constipation effectively with over-the-counter OTC products. We treat bloating and dysbiosis as well. A proper regimen, a bowel regimen, taking probiotics and fermented foods, which are good for you anyway, regardless of whether you have Parkinson's disease or not, are recommended to increase levodopa tolerance if someone is having gastrointestinal issues. We also resort to medications, as I've alluded to before, carbidopa, COMT inhibitors, and some other medications which can facilitate gut movement, decrease constipation. And some of these are listed over here. We don't have to go through each one of these at this time. I've explained this in the article that should come out in the next couple months. Or if you have a separate question, you can, write me or put it in chat. Orthostatic hypotension is the phenomenon of dropping your systolic blood pressure when you stand because of autonomic dysfunction in Parkinson's disease. As you know, when you stand, our arteries constrict and blood is automatically pumped up towards the heart and the brain. But that mechanism fails in Parkinson's disease, and the degrees of failure are very different in different individuals. Some people have very mild orthostatic hypotension and others have very severe. If it is mild orthostatic hypotension, then hydration and salting your food. Salting is very important. It really increases blood pressure, but it is not recommended if you have congestive heart failure, kidney disease, or if you're on a salt-restricted diet. Compression stockings and abdominal binders, as cumbersome as they are good non-pharmacological ways of increasing blood pressure when you stand. Avoiding really hot environments, eating small, frequent meals that are not very rich in carbohydrates, and of course, exercising fall preventions are good ways of minimizing orthostatic hypotension, which may result due to levodopa or which may exist regardless of taking levodopa. And then we have got the pharmacological arm that we look at in parallel. We want to exclude medications that can cause low BP. And we have a whole bunch of other medications to push the BP up a little bit while being cognizant of supine hypertension. And if there is an underlying cardiovascular concern, atrial fibrillation, arrhythmias, someone has a pacemaker or a heart problem, we always want to get a cardiovascular consultation. The third intolerance to levodopa is quite problematic. And this happens in advanced Parkinson's disease at very high doses. If someone has psychiatric and cognitive issues right in the very first couple of years that prohibit or preclude taking levodopa, then one needs to come back to the drawing board and determine if they actually have Parkinson's disease or is it diffuse Lewy body dementia. We got to eliminate medications that can exacerbate psychosis, and there are a few of those. Anticholinergics, we got to adjust the levodopa dose. And then I always involve my psychiatric and psychological colleagues to assist me in a particularly difficult case. And we have an armamentarium of medications that can treat the psychosis separately so that the patient can continue to take levodopa. Now, I know that a lot of people complain of sleepiness, fatigue, and behavioral changes with levodopa. These can all be individually treated, but because of the time limitation today, I cannot go into troubleshooting each of these issues, but they can be treated so the tolerance of levodopa can be increased. All right, so what is slow gut? Slow gut syndrome is the phenomenon of very slow passage of food, medicines, etc., from the mouth down to the rectal area where things are excreted. And Parkinson's disease causes a slowing down of the entire gut due to the issues with the nervous system, which controls the gut. The gut has its own nervous system called the enteric nervous system. And again, in the article that's coming up, I've described that in detail. And we will also be talking about the enteric nervous system on February 16. This enteric nervous system fails or actually slows down and doesn't function well in Parkinson's disease, and as a result of which the stomach does not empty its contents. And what you see on this particular slide is a levodopa carbidopa pill that is stuck in the stomach. This is the internal portion of the stomach an hour and a half after someone's taken it. And if that pill is stuck in the stomach because the stomach is not emptying its contents into the intestine, then you can have problems with absorption. You may not, quote unquote, turn on. The pill is not obviously absorbed. It doesn't get into the brain. So gastroparesis is a term we use to describe a stomach that is not emptying its contents appropriately. This can be seen in many conditions, including diabetes, due to autonomic dysfunction. And then we have other things such as constipation and dysbioses, which need to be taken care of so that oral levodopa can travel smoothly from the mouth and into the small intestine where it is absorbed. Obviously, if it is not absorbed, it is not going to be very effective. How about things that block levodopa or block the absorption of levodopa into the brain? Well, one of it is protein. We try to tell people to take levodopa at least 30 minutes before a meal. You do not have to decrease your overall protein intake per day. Protein is really important, although there is somewhat of an overemphasis on a highly protein-rich meal in America for some reason. I think about 20 to 30 grams should be more than sufficient. Or you can push your protein towards the nighttime and have a relatively protein-free period during the day in order to absorb your medication. That's another tip. There are certain medications that actually block the effect of levodopa in the brain. High doses of B6 are not recommended because levodopa then gets converted to dopamine in the body, which is not a good thing. Iron salts can decrease the absorption of levodopa, but iron salts also worsen constipation. So that's an issue. And then there are a whole group of medications that we look at when someone comes into the clinic to make sure that they're not on, or we have to consult with their prescribing physicians to minimize or eliminate, if possible, antipsychotics, antiepileptics, cardiovascular medications, antidepressants, anti-nausea medication, metoclopramide, which is very commonly given to the hospital, and it's called Reglan. It's a big no-no. It is given in the hospital to people who've had abdominal surgeries to facilitate the movement of the gut. Metoclopramide blocks the effect of dopamine and can significantly worsen Parkinson's, so it's not recommended. There are certain cancer drugs and anesthetics that can blunt the effect of levodopa. And then there's a couple medications that are not available in the US, but for those of you who are traveling to Canada or Mexico, etc., if you have vertigo or nausea, you can purchase these medications over the counter, flunarizine and cinnarizine, and it's a big no-no. Please do not use these medications because they can make your Parkinson's significantly worse. And how about motor symptoms? Do they all respond to levodopa equally? Well, ideally they should, but unfortunately not. In decreasing order of efficacy, bradykinesia responds the most, and speech and swallowing don't respond as well to levodopa. Stiffness responds very well. Tremor is an interesting thing. About 1/3 of people with severe Parkinson's disease tremor may not respond adequately to levodopa. And that's when we talk to people about surgical treatment of Parkinson's disease. Gait and balance, manual dexterity may respond to a certain extent. So if someone has a very prominent gait and balance issue, and levodopa is not working to improve these symptoms, then that is understandable because it doesn't work as well for gait and balance as it does for bradykinesia. But on balance, taking levodopa improves all of these motor symptoms to some extent, some more than the other, compared to someone who is not taking the medication at all. In terms of its indication, as I mentioned earlier, levodopa is indicated for the treatment of motor symptoms, not non-motor symptoms. For instance, if someone is having orthostatic hypotension or a cognitive and behavioral issues, you don't want to give them more levodopa. Not only will it not help, but it might actually make things worse. How about levodopa responsiveness to older in older individuals? And we've seen this in our clinic that late onset Parkinson disease over age 80 or over age 75 may not be as responsive to levodopa as young onset because of mixed brain pathology. And what I mean is, unfortunately, as we grow older, we accumulate other conditions that can coexist with Parkinson disease. Parkinson disease, unfortunately, does not make us immune to other conditions such as Alzheimer's disease, vascular disease, or tiny strokes. They can present as white matter disease, normal pressure hydrocephalus, which is a ballooning of the spaces in the brain that hold water, and some genetic mutations such as TDP43. If these conditions are present separately with Parkinson disease, levodopa is not going to be very effective in treating motor symptoms from these diseases. A lot of these diseases cause symptoms similar to Parkinson disease, but they are not as treatable as Parkinson disease. So when we have looked at brain pathology and post-mortem autopsy of people who have had late onset Parkinson disease, we have recognized other lesions besides the ones that Parkinson disease causes, such as Alzheimer's plaques, hardening of arteries, etc., which could explain why levodopa might not be as effective in very late onset Parkinson disease. All right, this is one of my favorite sculptures. It's called Warrior with Shield by Henri Moore, again, in the Minneapolis Institute of Art. It's got a dimensionality and it looks different from different angles. So once you've done a tour of the sculpture garden, you walk right into the Institute of Art and see these beautiful paintings and sculptures. Very impressive. What kind of levodopa formulations are available currently? Well, the most common one is Cinemet, which is carbidopa levodopa 25/100. There is a CR formulation, which is not very well absorbed in some individuals. In some individuals, it is. Parcopa 10/100 I don't use commonly unless it is due to a rescue, which is you have sudden freezing, a sudden off. 50/200 CR is primarily for nighttime use. And that's what a tablet of carbidopa levodopa looks like most commonly. There are some blue-looking pills as well. Cinemet 25/50 is a big no-no. I would not recommend this formulation. The ratio of 1:10 carbidopa to levodopa is not recommended. Ideally, the ratio should be 1:4. And then you have Rytary, which I really like. It's been a game changer in a lot of people in my clinic because of the mixture of immediate release and extended release. But unfortunately, currently, it is really expensive and we have to jump through hoops to get this to people. How about other formulations? We have the transnasal formulation. I'm sorry, I apologize. It's the oral formulation. The transnasal formulation is being worked on. This is an oral inhaler called Inbrija. It's basically 2 capsules of levodopa, and it is used as a rescue medication, for instance, early morning off. You inhale it, you take a puff of it, it is levodopa absorbed through the lungs directly into the brain. It bypasses the gut. And so the onset of action is very immediate, but the duration is only about 30 minutes or so. And then we have another formulation which is used for advanced Parkinson disease called Duopa. This is a gel that is pumped directly into the jejunum where levodopa is mostly absorbed. Therefore, you don't have to worry about gastroparesis. And it works very effectively for those people who have motor fluctuations or have advanced Parkinson disease. How about the other medications? There's just several kids on the block over here. The most common medication that is used in place of levodopa is a dopamine agonist. But the problem with these medications is, having used these for many years, is there's a very high percentage of people who complain of sleepiness, sudden sleep attacks when they're driving, weight gain, lightheadedness, leg swelling, even psychosis, and worst of all, impulse control disorders, overeating, hoarding, shopping, hypersexuality. So the physician and the patient and the spouse have to be constantly vigilant with these medications to make sure none of this is going on. The side effect profile is not great, and I dare say that after a couple years of using this medication, we have to introduce levodopa because these medications are not as effective as levodopa. And then there are others that we used in different combinations depending upon the patient's needs, and we call all of these adjunct medications. Another very fun sculpture, this is called Flight of Night. I like the way the sculpture is balanced on a sphere. I think it is quite remarkable. And again, this is in the Minneapolis Institute of Art. This transitions us back to the case study. So our Mr. HW was given pramipexole, which caused leg swelling and dizziness. A reticodine patch, which is another dopaminergic agonist, caused a skin rash, which is a common side effect. Rasagiline only minimally improved symptoms, and he was educated about the benefits of levodopa and Parkinson's disease. Carbidopa levodopa was initiated, gradually increased to 600 milligrams per day in divided doses, and he realized a significant improvement of slowness, stiffness, speed of walking. Overall, his quality of life improved, and he was able to go back to work as a mechanic. But that's not the end of the story. As we know, in Parkinson's disease, there is a role for multidisciplinary treatment. Levodopa is just but one tool in our toolbox. So what else did we do for Mr. HW? Because he had this dream enacting behavior, we introduced melatonin, which decreased it significantly. There were dietary changes made to improve the absorption. Daily sensible exercise was suggested, which improved constipation and physical endurance. Dermatological examinations are important in Parkinson's disease because there is a higher risk of melanoma in Parkinson's disease, and he had the benefit of that. Fortunately, basal cell cancer was identified early on. It was treated. Lee Silverman voice technique was used, which improved speech because, as you know, levodopa does not improve speech adequately. And then his primary care was completely up to date, which is very important, whether you have Parkinson's disease or not, but especially in Parkinson's disease. And overall, his quality of life continued to improve. So I'm just going to use this cartoon to illustrate the importance of levodopa, as it is better than all of the medications combined, and it remains the gold standard of treatment, so much so that it will never go out of fashion until we find that holy grail to treat Parkinson's disease, to slow it down, to reverse it. We will continue to reformulate, repurpose levodopa so that it effectively gets into the brain area. Right now, the delivery mechanisms are not very effective. So what we are looking at is an intranasal administration in which levodopa gets directly from the nose into the brain, bypasses the gut. Also intraventricular and intrabrain injections right to where it is needed to make it very precise, and also using intravenous forms of levodopa, using focused ultrasound to disrupt the blood-brain barrier a little bit so that levodopa can cross over easily into the brain without competing with protein. We have several pro-drugs coming up that are not metabolized in the gut into levodopa until they cross into the brain. So that improves the delivery of levodopa directly into the brain. And then we are looking, towards the subcutaneous infusion of levodopa and carbidopa, which I think the FDA is reviewing to see if it is going to approve or not, and that is a subcutaneous under the skin delivery of levodopa. So I'd like to end with the most quoted scientist in the US. It is Dr. Warren Allenow, who works at Mount Sinai in New York. He said it really well, and I completely agree with him, that levodopa is currently the best symptomatic therapy for Parkinson's disease, nothing more and nothing less. And I think that should be my penultimate slide. The last one is just a reference for you guys. This is a very good book written by Dr. Asklog from Mayo Clinic. It is from 2015, so it doesn't have all the updated treatments. But if you really want to maximize intake of levodopa, minimize side effects, and also treat other non-motor symptoms effectively, try to get a hold of this particular book. And with that, I shall conclude, minimize my slides, and hand it over to Jen. And I'm sorry I went over a little bit, Jen.
You know, I told him it was going to be over an hour. So your presentation was an hour. And I just want to take a deep breath. And I want you to take a deep breath. And why doesn't the audience just open their arms really big, like you should do, and stretch out right before we get started? Maybe go to the right, go to the left. Just, you know, shake it off before we get into the questions. Yes, yes. In yoga, I call that a yoga tantrum. We just have a little tantrum here.
Love it. Love it.
Lots of questions, lots of information.
Okay.
I've been kind of going through the questions and going like, he just addressed that. He just addressed that. Phew, there's a lot though. So we're going to just jump right in. Question asking for a friend from my friend Barbara. How does a patient know when to bring up a change in dosage, strength, and frequency with their physician?
Well, it's a great question. Is basically how to monitor your own symptoms. If you're on an adequate dose of levodopa, we know that its duration of action is about 3 to 4 hours. If you notice that at the end of the dose and before you start, you take your next pill, Parkinson's symptoms are coming back. Your tremor, your stiffness and slowness is more obvious at the next dose, then you know that you're wearing off. And that's called wearing off. And that would be an important thing to bring up to your neurologist or movement disorders doctor, who typically asks these questions as a routine part of the consultation. How is the medication working? Is it wearing off or not? And then the other thing is the adequate dose. If you prescribe levodopa and you don't see any improvement in your motor symptoms, then it's important to alert the physician, and that means the dose is not adequate. So that's how you monitor your own symptoms.
Okay, great, great. And you can track your symptoms on a piece of paper. You can do it on an app. There's lots of, lots of things. And then you can communicate that with your physician. Yeah. Yes. APDA has a symptom tracker app.
Yes. And I would highly recommend that we get it.
Thank you. Can you mentioned this kind of briefly when you were answering that question. Can you do a real quick, I guess, idea of on and off and what that means? If somebody hasn't really experienced it, what are they looking for?
On is basically an improvement of Parkinson's symptoms. That's as simply described as that. If someone has tremor, stiffness, and slowness, and you give them levodopa, we expect with an adequate dose, at least a 50 to 60% improvement. So one needs to be cognizant about, that decrease or improvement, and that can manifest as decreased tremor or improved arm swing, better handwriting, improved speed of movement in hiking or, walking, etc. So that is basically on an improvement of symptoms. Off occurs when the medication basically starts getting metabolized and excreted from the brain when it is time to take the next pill. And then the symptoms start coming back, Parkinson's symptoms, and that is off. I would give an analogy to insulin and diabetes. When you take the insulin, it has a duration of action. And once that insulin dose sort of wears off, the blood sugars creep back up. So what the endocrinologist wants to do is keep the insulin level high enough so the blood sugars are always in check. So that's what we try to do in Parkinson's disease, keep the dose high enough so you're almost always on.
Okay, great. And that actually leads itself into another question that has been talked about. Do you have any advice and strategies if you miss a dose, you forgot? Like what do you do with that? And you're starting, your Parkinson's symptoms are creeping back in.
That's exactly right. And if you cannot wait for the next dose, and depending on when you missed it, if it's only been 10 minutes, it's a different issue, as opposed to it being over 3 hours. So when you've missed it becomes important. And if you cannot wait for the Parkinson's, for the next dose, you take it right away. But if you are okay and you're not experiencing any problems, you can wait till the next dose. So missing a dose is not hurting your brain in any way. It's not causing any problems in the brain, so that you don't have to get anxious or panicky about missing a dose. However, if the symptoms are coming back, it's okay to take the next dose right away, and then you can space it out like you have been earlier, or you can take the next dose, at the time that it is that you need it, particularly if you're turning off. So you can monitor your own symptoms. We don't like people to miss more than a couple doses here and there, because ultimately the brain does not like an erratic distribution of levodopa. In non-Parkinsonian brains, levodopa is constantly secreted. There is the basal level, as we say, that maintains brain tone. We cannot emulate that currently in 2023, although that's the goal. Is to emulate what the brain does with dopamine. But what we can do is insist that people take it regularly, so the levels are as high and as steady in the brain as possible.
Great, thank you. I had a couple of questions related to levodopa and exercise, particularly, I guess it's a myth, fact, I'm not sure, about the burn rate of levodopa when you're intensely exercising. A couple people were talking about in their boxing class where they go through this intense exercise, and then at the end, they're tremoring more. And so they're wondering, is the levodopa burning faster as they're exercising?
Okay, that's a really good point. First of all, you take a step back, you need levodopa to exercise. So that's important. So have an adequate amount so you can exercise. Number two, any activity that increases the amount of adrenaline in the body, it can also mimic a worsening of symptoms. So we know that when people are stressed or anxious, their tremor gets worse. And that's not because they're turning off. Adrenaline, unfortunately, basically makes the symptoms worse temporarily. So it could be one of two things, that because after we exercise, we have the endorphins and the adrenaline flowing through, and you might experience a temporary worsening of the Parkinson's symptoms. Now, the opposite is also true. Some people say the Parkinson's symptoms improve significantly with exercise, and they don't require as much levodopa. So I say it's neither fact nor fiction. The truth is somewhere in the middle. It depends on how you're wired. And if you consistently feel that you need more levodopa at the end of intense boxing, and you're turning off or you're burning through, please alert your prescribing physician, and they can give you extra levodopa or tell you how to minimize that burn through. And that is definitely doable with rescue medications such as Inbrija or extra levodopa.
Mm-hmm. Can you briefly address, I'm having trouble with my screen here. I can't find my questions now. Sorry. Can you briefly address the rescue medications? Specifically, there were a couple questions about like on Rytari, it's not lasting 4 hours. What are the options of doses of either Sinemet in between doses or a rescue medication? And then there were other questions about, how do I know if I need to use a rescue medication, and is it too much? Like, is Inbrija too much getting into my system? So can you address that?
Yes. And before I address that, I would also point people to the Pathfinder article we wrote on levodopa optimization. If you'd send the link, that has
I will do that in your post-event email. I'll send that link to that article.
We had a table we created on how to use these medications. Inbrija is a good one for rescue, and it's not, you don't get too much. You get only as much as you need to turn on, but it's very expensive. And I remember one of the questions saying, well, if you're not able to afford Inbrija or get it, then what do you do? Then we basically work with the Rytari or the carbidopa, levodopa to prevent the off symptoms. and to minimize the need for rescue. So it is important if someone is taking medications only 4 times a day and they're turning off, it is very important to fix that baseline amount of medication before you prescribe Inbrija. We can work with what they are taking by increasing frequency, increasing dose, so that they would not need rescue. But if despite that, if people are needing rescue medications, there are other medications, including Khemani, which is a sublingual that you can use, and even extra Levodopa that you can chew. It's not very tasty, it is bitter, but you can actually chew that. And if you take it with a fizzy drink or dissolve it in ginger ale or soda, it acts really fast. And then, of course, there's the apomorphine injection, which has been around for a very long time. In fact, more than Inbrija and Khemani that can be used. Apomorphine is an injectable rescue. It works really well. We just have to be careful about the potential side effects of the rescue drugs. Apomorphine can drop blood pressure, can worsen psychosis. So it needs to be used in the correct individual. It needs to be given appropriately.
Okay. We only have a few more minutes, folks. I'm sorry. Dr. Khemani does have a hard stop, so we are not going to get to everything. I'm going to try to be very specific to Levodopa, staying on this topic. We're getting a lot of sleep questions and cannabis and things like that. Those resources are coming, or they're out there. If you really want specific resources, email me. I'll see if I can point you in a direction of an article or a webinar that is on a particular topic. And these give me good ideas for future topics. So can you talk a little bit, there's been several questions about dosing. Yeah. Early on in Parkinson's, the 3 times a day, 4 times a day, how do you know whether it's an effective dosage or not, and tweaking it sort of yourself? I actually hear from patients about tweaking their own dosage a little bit. So can you talk a little bit about that? Yeah, how the dosing is decided?
Yeah, I might also have a slide, and if I'm not able to articulate that, then I might show that slide. Should I just show it, you think?
Sure, why not?
Okay, let's see if I can show
if you have it quickly.
Okay, right. Can you see my screen, Jen?
Yes.
Okay, so this is a slide that I'd made for a separate presentation, and this actually demonstrates what happens over time. This slide shows the duration of levodopa based upon the concentration. In the early part of Parkinson's disease, the medication is taken, you turn on, and it lasts for 6 to 8 hours. But as Parkinson's disease progresses, unfortunately, when you take the medication, it may not last as long. You have much higher off periods. It peaks quickly, causes dyskinesia, and falls down. And the same thing happens as the disease progresses. So the duration of action gets shorter and shorter. So when this happens, we look to the adjunct medications to help us. There is opicapone, there is entacapone, etc. So the dosing depends upon the history the patient provides to the physician. It depends on that intake. Then the patient say, my medication is not lasting as much. Then the physician decides how frequently the patient needs to take the medication and how much medication they need for effective functioning. As is based upon the exam and the face-to-face or face-to-screen interaction with the patient and the physician. And and then in follow-up, we do the exam to determine if the dose of medication is adequate. So we listen to the patient and the caregiver, but we also have our own exam. We do compare numbers to determine if the dose needs to be increased or if it needs to be decreased or changed in some way. So we have tools to determine that. And one of the tools is that Unified Parkinson's Disease Rating Scale that we use in our clinic.
Mm-hmm. Okay, great. Thank you. I think that's kind of all we have time for.
I can stay for a few minutes more.
Okay, a few minutes more. I'm like, which ones? So I do want to address one quick thing because it is concerning enough. Is ropinirole a dopamine agonist? Let me clarify that. Okay, so when you're on a dopamine agonist and you get those addictive things like gambling or excessive eating, things like that, is your option to go off that dopamine agonist and go on to levodopa? And should that be something they should really be on top of if they're if they're recognizing, they have insight into, I have these things that I'm doing.
Yes, that's the very first thing. Recognize it, either the patient or the spouse. Call the physician right away. The sooner we treat this, the better. And ropinirole can be given by itself or with levodopa. It depends on what the patient is taking in terms of other medication. If it is only ropinirole and nothing else, or pramipexole or vertigotine, some other dopaminergic agonist, the first thing we got to do is gradually decrease the dose. You cannot stop it suddenly. If you do, then there is a phenomenon that occurs called DAWS, D-A-W-S, dopamine agonist withdrawal syndrome, which can cause severe depression and which can cause Parkinson's to get worse. So just like we build these pills up gently, we gotta taper them off very gently as well. And if the patient is on levodopa, then we increase the levodopa in parallel, or when the ropinirole is discontinued. And if they're not on levodopa, then we introduce levodopa as the medication to treat these symptoms once the dose is decreased. Now, the dose may not need to be eliminated. I have a lot of people whose doses are decreased to a certain point and the symptoms all go away completely, and then we can keep them on that particular dose.
Okay. Why would generic carbidopa levodopa not be working, but Rytary does?
Very good question. I think that speaks more to the term generic than carbidopa levodopa, because I haven't heard this a lot. This is more common in epilepsy, where generic epilepsy drugs may not work as common as brand name, but ideally it should work as well. The problem with the regular or generic carbidopa levodopa is its immediate release. Rytary is a mixture of immediate and extended release. So it does work. That needs to be sorted out. It does work, but it may not work or last as long as Rytary. Because when we start medications, we never prescribe Rytary at the get-go. Number one, it's unnecessary. Number two, insurance companies are not going to cover it. So even today in the US, I think 80% of people are taking generic carbidopa levodopa and are doing very well on it. The problem is the duration of action. And Rytary has the benefit that you can take it less frequently, and it has a much longer duration of action than generic carbidopa levodopa.
Okay, great. Thank you. There's a lot of really specific questions, and maybe I'll circle back with you and just take a look at them, and we can send an email to the folks that we'll have record of that, just because some of them are about different drug interactions, and maybe the simple answer is ask your doctor about that, which, with different medications acting with levodopa.
And there is a tool that doctors have called micromedics. Even I don't know all the interactions because I don't prescribe a lot of the other medications that people take. So I use that tool in the office to put everything into a blender, I call it, and then see what comes out the other end. And doctors have an ability to be able to do that.
Okay, so I want to, because there have been several questions about this, and you addressed it in your talk, but can you talk just a little bit about food and levodopa, meals, that sort of effectiveness and the competition of levodopa with food and what people should do, just to give them some tips and tricks and advice?
Right. One of the issues with levodopa is the short duration of action. And it is really problematic to take it 4 times a day or 5 times a day. So what I tell people is either fix your meal times or fix the levodopa times. You got to fix something. But if you get up at a different time each day and eat meals at different times each day, then it is very difficult to take levodopa a half hour before a meal at every day. But the brain prefers that. So some amount of discipline is required. There's no getting away from it, So please fix your meal times, or if you don't, please fix the levodopa times, and then you can move the others. And it is perfectly okay to take levodopa with a meal. You're going to a concert, you're sitting down with people, just the meal falls right at the time that you're going to take the carbidopa, levodopa. There is no bad interaction. It's just that the levodopa may not be fully absorbed. So yes, it is not toxic or anything like that to take with food. It may be just less effective. So we don't want people to go into a tizzy about, food times and levodopa times. You make a schedule, and if you stick with it, I think you would be able to accomplish it. And you can, if you miss a dose, not a big deal. If it falls on a meal time, not a big deal. But if you can take at least 80% of your doses, as you're supposed to, I think you're doing a great job. In fact, people come and tell me, Jen, hey, listen, I've discovered that I cannot eat a steak when I'm taking levodopa. I didn't even have to tell them that, because they realize that their tremor does not improve when they take it with a massive amount of protein. So patients have a lot of insight, and they do, they basically fashion their day. But if they're not able to, then we can help them. APDA has fantastic timers, right, Jen? The pill timers, what is that? I thought that there was a sort of pill box or something like that.
I mean, there is a pill box available. It's not an APDA thing,
I
but
see.
there are pill boxes that will pop up when it's time for you to take your next dose. That's the fancy way of doing that, or set a reminder in a phone or something like that, which is what a lot of people do.
That's what a lot of people do, and it works really well. You just have to get over the initial hump of getting into that disciplined state.
Sure. All right. Thank you. I know there's a lot more questions out there. We could talk about this subject for a long time. And I really, truly appreciate your insight into this and presenting it. Our next Parkinson Pathfinder, which is coming out in a couple months, will have a more extensive, we'll have an article about levodopa intolerance. And we'll also address some of these myths and facts as well, because we do have an article about that. So putting that together. Everyone who is registered for this program, all of you here who got the link, will get a post-event email. It will have Dr. Khemani's slides on it. It will have the video to this. And just some additional resources for you on this topic. I'll put a link to where you can find the articles in our Parkinson Pathfinder magazine. So we'll give you some resources that should be coming out. Let me say by Friday of next week is going to be my goal, to get all of that together. So Dr. Khemani is going to be back at an APDA virtual conference. This is our 2-day conference in February. It is February 15th and 16th. And there's a really great agenda with a bunch of different people and topics. Dr. Khemani is going to be talking about the gut, correct?
Yes.
Yes, I thought so. And talking about some of that slow motility and things like that. So you might want to tune in for that. It is free. I just think it's going to be a really great seminar. So you can I will put a link to that in your post-event email, and you can also find it on the APDA website. For us, our next Take Control is going to be Thursday, March 23rd. Dr. Kimmy Sue, who is a movement disorder neurologist at University of Washington, is coming to speak. I don't know what she's speaking about. She and I are still talking about the topic. So stay tuned for that. Stay tuned to our weekly email, the news you can use to get information about that and any other programs that we do. And we just have some great programs coming up. We are also locally, if you are in the greater Puget Sound, Seattle area, we are really excited and getting ramped up for our Magica Hope Gala and fundraising auction on March 11th. Saturday, March 11th, we are back in person for the first time in 3 years. It is an important, wonderful event. We hope that we're going to be able to live stream it and have some online auction things. So I'll put information about that in the email, and we'll hope you consider joining us. And last but not least, if you enjoyed this program and you are in a position to do so, we do take financial contributions and appreciate those contributions because they allow us to do all the work that we do in providing programs, in giving financial support to people, in funding exercise programs, and really pulling the Parkinson's community together. So So thank you. Thank you for being here. Dr. Khemani, thank you for all of your insight. Do you have any parting words for our audience today?
No, I thank you, APD, thank you all. And this is more so long, not goodbye, because we'll be seeing each other online again mid-February, February 15th and 16th. Until then, have a great time, great weekend. Bye, guys.
Thank you. I hope you have a wonderful afternoon, everybody, and a great weekend. Thanks for joining us. Take care.